This is the second lecture on ischemic heart disease, in which we will focus on patients with acute coronary syndromes. In the past lecture, we discussed patients with stable angina who have a stable plaque obstructing more than 70% of the coronary artery. We now will see how these patients progress into acute coronary syndromes. We will go over the pathophysiology of patients presenting with acute coronary syndromes, the clinical presentation, how do they present to us, their diagnosis and when they are classified, the treatments that we offer them, and the complications that they might face while they're hospitalized with these. Let's start with pathophysiology. The hallmark of acute coronary syndromes is plaque rupture. For reasons that are still unclear, patients with stable coronary artery disease suddenly have rupture of the plaque, usually at its shoulder. This will expose the lipid core to the blood, which will lead to platelet adhesion. The platelets get activated, they invite more platelets, leading to platelet aggregation, and finally we have thrombus formation with total occlusion of the blood vessel. So three important things to remember in the pathogenesis of acute coronary syndrome: plaque rupture, platelet activation and aggregation, and thrombus formation. It's important to remember these because this is the basis based on which we treat these patients, which we will discuss in future slides. This is a pathological specimen from a patient who was hospitalized with an acute coronary syndrome, and you clearly see that there are fissures in the fibrous cap of patients who have acute coronary syndromes, shown here in the red arrows. This is another pathological sample from a patient who was hospitalized with acute myocardial infarction. Again here, you see rupture of the plaque and a clot forming inside the vessel, leading to acute myocardial infarction, and in this case to death. How do these patients with acute coronary syndrome present to us? It's very important to distinguish between the clinical presentations of patients with stable angina and those with acute coronary syndromes. Patients with stable angina, as we discussed in the previous lecture, they complain of stable reproducible chest pain on the same level of exertion that has been ongoing for several months or even years. Most of the time, patients with stable angina, they present to our clinics in the outpatient department. On the other hand, acute coronary syndromes, which are due to acute plaque rupture and thrombus formation, these patients usually present to the emergency department, and they can have one of four usually clinical presentations. They either have new onset angina of less than 1 month duration, either angina at rest, or worsening of previous stable angina. A patient could be having stable angina, complaining of chest pain whenever he walks 5 blocks. Now, recently, he started having chest pain whenever he walks 1 block. This is an indication that this patient is having acute coronary syndrome. Or severe persistent non-resolving chest pain, which is what we see in patients with acute myocardial infarction, which we will discuss later. We will now go over the diagnosis and classifications of these, which is usually based on 3 elements: their clinical presentation, the electrocardiographic findings, and the cardiac biomarkers that are used in their assessment. Let's start with the ECG. Patients with acute coronary syndromes can present either with a normal ECG, as we see here in this strip, or with ST segment depression, or T-wave inversions, or ST segment elevation. The second important element that is used in the diagnosis and classification of patients with acute coronary syndromes are cardiac biomarkers, which are specific proteins that are present inside the cardiac myocyte. Whenever there is myocardial infarction or cell death, these proteins leak into the bloodstream where they can be detected by special assays. The 2 most common proteins that are used in the assessment of acute myocardial infarctions are CKMB and troponin. you see here the time frame of the rise and fall of these enzymes whenever you have myocardial infarction and cell death. Nowadays, we only use troponins as a cardiac biomarker in patients with suspected acute myocardial infarction because they are more sensitive and specific. They start to rise 3 hours after the onset of infarction and they peak at 24 hours. It's very important to obtain serial measurements in patients with suspected acute myocardial infarction. The area under the curve reflects the size of the infarct in patients with acute myocardial infarction. In the next two slides, we will go over the classification of patients with acute coronary syndromes or ACS patients, and we will see how do the presentation, ECG findings, and troponin help us in making the distinction between the different classes. ACS patients are divided into three categories: ST elevation myocardial infarction or STEMI, non-ST elevation myocardial infarction or non-STEMI, and unstable angina. Let's start with ST elevation myocardial infarction. These patients usually present to the emergency department with severe oppressive persistent chest pain. The ECG will show ST segment elevation, and that's why we call them ST elevation myocardial infarction, and the troponin is always positive. For non-ST elevation myocardial infarction and unstable angina, they usually have a similar presentation. They have either new onset angina or worsening of previous angina or angina at rest, but the pain here, unlike ST elevation myocardial infarction, the pain is usually less than 30 minutes in duration. The ECG in both non-ST elevation myocardial infarction and unstable angina, both have no ST elevations, and that's why, or else we would have called them ST elevation myocardial infarction. But they can have any other findings on the ECG. They can have ST segment depression, they can have T-wave inversions, or even a normal EKG. Now, how do we distinguish between the two? We distinguish them based on the troponin. If the troponin is positive, then this becomes a non-ST elevation myocardial infarction. If the troponin is negative, then this is unstable angina. Now, because non-ST elevation myocardial infarction and unstable angina have very common features, they are sometimes lumped together and called non-ST elevation ACS patients. Let's go over this classification again, but do it the same way as we do it in clinical practice. So let's say we have a patient who presents to the emergency department with symptoms suggestive of ACS, indicating that they have either new onset angina or angina at rest or worsening of previous angina or severe persistent chest pain. The first thing we do in these patients is to get an ECG. If the electrocardiogram shows ST elevation, then this patient will be labeled as ST elevation myocardial infarction, and the troponin, as we said in the previous slide, will always be positive. If the ECG shows no ST elevation, it shows either ST depression or T-wave inversion or even normal, then this patient would be called a non-ST elevation ACS patient. Here is the place of troponin in classification. We order a troponin. If the troponin is positive, then this becomes non-ST elevation myocardial infarction, and if the troponin is negative, then the patient is labeled as unstable angina. So it's important to remember that to label a patient as myocardial infarction, whether STEMI or non-STEMI, you always to have a positive troponin. The troponin, the high cardiac biomarkers, are the hallmark of acute myocardial infarction and myocardial necrosis. Let's go over now the treatment options for patients with acute coronary syndromes. To understand the basics of treatment of these patients, we need to go back to their pathogenesis. As we said earlier, the pathogenesis of ACS is based on three important elements: plaque rupture, platelet activation and aggregation, and thrombus formation. So the basics of pharmacotherapy in patients with acute coronary syndromes is going to be antiplatelets and anticoagulants. And of course, because we have a occlusion of the coronary artery, a very important option in addition to pharmacological therapy is going to be opening these occluded arteries mechanically. This diagram shows the activation pathways for platelets, which can be done either through thromboxane A2 or the ADP receptor, or the glycoprotein 2B3A receptor. Aspirin has been the traditional antiplatelet medication, which works by blocking cyclooxygenase, but aspirin is a relatively weak antiplatelet medication. Newer and more potent antiplatelet medications were introduced, such as clopidogrel, which is an ADP receptor antagonist. Clopidogrel works synergistically with aspirin in patients with acute coronary syndromes. There are other ADP receptor antagonists that you have to be aware of, which are shown here. These include ticagrelol, prasugrel, and clopidogrel, as we talked about. Let's go over now the treatments that are offered to patients with acute coronary syndrome. All patients should be receiving aspirin, whether STEMI, non-STEMI, or unstable angina. All patients should receive a second and more potent antiplatelet drug, such as clopidogrel or the other medications that I showed you earlier. They all should receive an anticoagulant, such as heparin or low molecular weight heparin. They all receive a beta blocker as an anti-ischemic medication. They all receive as well nitrates, also as anti-ischemic medications. Calcium channel blockers are not used except if the pain is not controlled with beta blockers or nitrates. It's also important to remember that calcium channel blockers are contraindicated in patients with heart failure or an ejection fraction less than 40%. Statins should also be given to all patients hospitalized with acute coronary syndromes. ACE inhibitors or angiotensin converting enzyme inhibitors are only given to patients with heart failure or an ejection fraction of less than 40%. Coronary angiography is performed in all patients with acute coronary syndrome. The difference is in patients with STEMI, coronary angiography is performed immediately on presentation, whereas in non-STEMI or unstable angina, coronary angiography is performed within 24 hours, but not necessarily immediately upon presentation. A very important distinction between STEMI and non-ST elevation myocardial infarction or unstable angina is that in STEMI, we need to perform immediate reperfusion, either with thrombolysis or primary angioplasty, and we will discuss that further in the next couple of slides. Whereas with non-STEMI and unstable angina, we don't perform immediate reperfusion with either thrombolysis or primary angioplasty. Let's review again the basics of pharmacological treatment in ACS patients. These patients should be receiving dual antiplatelet therapy with aspirin and clopidogrel in order to prevent further platelet activation and aggregation. They all should be receiving anticoagulation to prevent thrombus formation. Thrombolysis to dissolve thrombi is only given in STEMI patients. It's not given in unstable angina or non-STEMI patients. Statins are used to stabilize plaques and prevent future plaque ruptures. Beta blockers are used as anti-ischemic medications, and they also prevent future cardiac events in patients with acute coronary syndromes. Calcium channel blockers are only used if beta blockers cannot be used, but they are contraindicated in patients with heart failure or an ejection fraction less than 40%. Nitrates are used to relieve chest pain, but it's important to remember that they have no impact on survival or future cardiac events. ACE inhibitors are used to prevent future ventricular remodeling. They are particularly helpful in patients with large infarcts, heart failure, or an ejection fraction less than 40%. For the next part of this lecture, we will focus on the management of ST elevation myocardial infarction, which has been the subject of extensive research and developments over the past 2 decades. Let's first briefly review the coronary circulation. The heart receives its blood supply from 2 arteries, the right coronary artery and the left coronary artery. The left coronary artery starts as a short, large segment, which then bifurcates into 2 large arteries, the left anterior descending and the left circumflex. The left anterior descending artery supplies the anterior and septal walls, and when it is occluded, it causes ST elevations in leads V1 to V4 on the EKG. The left circumflex artery supplies the lateral wall, and when occluded, it causes ST elevations in leads 1, AVL, and leads V5 to V6. The right coronary artery supplies the inferior wall, which is manifested on the EKG in leads 2, 3, and AVF. STEMI or acute myocardial infarction has several warning signs that are listed here on this slide. These patients usually present to the emergency room, as we said earlier, with severe and persistent chest discomfort that is described as pressure or squeezing or burning. They might have discomfort in other areas of the body, such as the arms, jaw, neck, back, or even stomach. And they also have sometimes associated symptoms, such as shortness of breath, cold sweats, diaphoresis, nausea, and vomiting. The wavefront phenomenon of acute myocardial infarction is an important concept that is directly related to the treatment of these patients. You see here a schematic of what happens to the myocardium when an artery gets occluded. At time 0, the segment of that myocardium that's supplied by the occluded artery becomes ischemic. As time goes on and as the artery remains occluded, you start seeing necrosis in the subendocardium that starts around 20 minutes after the occluded artery. If the artery remains occluded, the necrosis starts propagating from the subendocardium to the epicardium, and that usually takes around 6 to 12 hours before you have a complete transmural myocardial infarction. This is very important for the management of these patients because it implies that if patients present with ST elevation myocardial infarction, you have to treat them as early as possible to save myocardium as much as possible and to save lives as much as possible. As you see in this slide, where you see on the y-axis lives saved per 1,000 patients treated, and on the x-axis the time from onset of chest pain to the treatment or to opening up the occluded artery. If the artery is opened as early as 20 minutes, you have a much larger number of patients that are saved as compared to patients who are treated very late after 12 hours, where a substantial number of patients would have died because of the delay in their treatment. These important pathophysiological concepts laid the foundation for what we call reperfusion therapy in patients with ST elevation myocardial infarction. If we believe that plaque rupture is the cause of acute myocardial infarction with acute thrombus formation, then a logical drug to use would be thrombolytic medications to dissolve that clot and open up the artery. These drugs were indeed tried almost 30 years ago in the famous ISIS study, which looked at the effect of streptokinase, which is one of the first generation thrombolytic medications, in patients with acute myocardial infarction. And that study showed that streptokinase was able to reduce the mortality in patients with acute myocardial infarction by 23%. In that study, they also showed that aspirin by itself can also reduce the mortality by 20% in patients presenting with acute myocardial infarction. And if you use the two drugs together, streptokinase and aspirin, they both have a synergistic effect, and they were able to reduce the mortality in patients presenting with ST elevation myocardial infarction by 39%. So streptokinase was the first reperfusion therapy to be shown effective in patients with acute ST elevation myocardial infarction. It reduced the mortality in these patients, and it was shown to open up the occluded artery in 60% of the patients. But it had a 0.5% risk of cerebral bleeds. So newer generation thrombotic drugs and second generation medications were introduced later on, such as TPA, which improved the patency of the infarct artery up till 80%, but it also had a 0.7% risk of cerebral bleed. And that's why investigators started looking for more effective reperfusion therapy with less risk of cerebral bleeds. This is where investigators started thinking of using mechanical intervention with coronary angiography and primary angioplasty to open up occluded arteries rather than using thrombolytic medications. Multiple studies were performed comparing primary angioplasty to intravenous thrombolytic medications in patients with ST elevation myocardial infarction, and all of them showed that primary angioplasty was able to reduce mortality, reinfarction, and it was able to reduce the risk of cerebral bleeds from 1% to almost 0.1%. These studies laid the foundation for primary angioplasty being an alternative reperfusion therapy for acute ST elevation myocardial infarction, being more effective in opening up occluded arteries with a much lower risk of cerebral bleeds. So in modern cardiology practice, mechanical intervention with primary angioplasty has become the preferred mode of reperfusion over thrombolysis in patients with ST elevation myocardial infarction, provided that it is done very quickly and without any delay. This is usually measured by what we call the door-to-balloon time, which is the time from the patient arrival to the emergency department to the time the artery is opened with a balloon or a stent. Ideally, the door-to-balloon time should be less than 90 minutes. The impact of the door-to-the-balloon time on mortality is shown on this slide, where you see a progressive increase in mortality if there is a delay in the door-to-balloon time. That's almost 3 times. So if you have a 150-minute door-to-balloon time, the mortality is almost 3 times than in patients who have a door-to-balloon time less than 90 minutes. And this is understandable because, as we said when we talked about the wavefront phenomenon in acute myocardial infarction, the longer you wait on patients with acute myocardial infarction, the more myocardium that is lost, which directly reflects on increased mortality in these patients. In the last section of this lecture, we will cover the complications that patients with acute myocardial infarction might develop. Mechanical complications in the setting of acute myocardial infarctions are relatively rare, but nevertheless, we need to be aware of them. One of these potential mechanical complications is papillary muscle rupture that can lead to acute mitral regurgitations. You see on the schematic on the left side the mitral valve apparatus. The mitral valve is attached to papillary muscles, which are very important in the work of the valve in opening and closing the valve. These papillary muscles have blood supply. If the artery supplying the papillary muscle is occluded, these muscles might become ischemic, or they might even necrose, and when they do that, they might rupture, as shown on the schematic on the right side. When they rupture, you will have acute mitral regurgitation. Acute MR secondary to papillary muscle rupture usually occurs 2 to 7 days post-acute myocardial infarction. It causes acute pulmonary edema, and in most of the cases it will require surgical intervention to replace the valve. Another potential complication of acute myocardial infarction is ventricular septal defect. The same concept is also here. The septum is supplied by coronary arteries. If one of these arteries gets occluded, you might also have necrosis of the interventricular septal wall, which will lead to a ventricular septal defect. This usually happens 3 to 5 days post-acute myocardial infarction, and again, it will require surgical correction. The third potential mechanical complication that patients with acute myocardial infarction might develop is free wall rupture, which usually occurs 5 to 14 days post-acute myocardial infarction. This is unfortunately a fatal event leading to sudden death because patients will have immediate cardiac tamponade, and usually we do not have enough time to take them down to the surgery. Other than mechanical complications, patients with acute myocardial infarction might also develop cardiac arrhythmias, such as ventricular fibrillation or ventricular tachycardia. These are the cause of sudden death in the acute setting of myocardial infarction. They also might cause sudden death in the long term, particularly in patients who have large infarcts with an ejection fraction less than 35%. These are usually treated with antiarrhythmic medications such as cordarone or with devices such as defibrillators. The last complications that patients with acute myocardial infarction might develop is congestive heart failure secondary to ventricular remodeling. You will have later 2 dedicated lectures to go over congestive heart failure, but I'd just like to note that acute myocardial infarction is the most common cause of heart failure, particularly in patients who sustain large myocardial infarctions with an ejection fraction less than 35%. And the most important measure to prevent heart failure in patients with acute myocardial infarction is by early treatment and reperfusion to limit the infarct size. In conclusion, we have went over in this lecture and in the past lecture the whole spectrum of patients with ischemic heart disease, those with stable angina, as well as those with acute coronary syndrome and acute myocardial infarction. We have discussed the clinical presentations of these patients, their diagnosis and management. We will have later a dedicated TBL session to further discuss and clarify these concepts. Thank you.